Thank you all for being here today. I just wanted to begin by thanking those who invited me to speak today. And I'm very excited to talk to you about some of the work that I've been doing the past few years in Aaron Fenster's lab. And specifically in this talk, I'll be talking about a new system that we're trying to incorporate into the clinic. So I'd like to begin by thinking about the patient perspective and what a patient usually goes through when they're diagnosed with something like liver cancer. So if we have a patient, say we have a patient, Howard. If Howard gets diagnosed with liver cancer, typically there's a very poor prognosis when considered on a worldwide scale. And of those diagnosed, liver cancer is associated with 5-year survival rates being the second and sixth highest of all cancer sites. And once Howard is diagnosed with this disease, some conventional therapy options that he's offered are open surgery. So being transplantation, where they actually remove the whole organ from the body, or resection, where they cut out part of the liver, which is beneficial because the liver can partially regrow itself. If he is eligible for this type of procedure, which it's often limited to 10 to 20% of patients, there's often a really long wait list associated with these types of procedures. And also, after going through with these procedures, there are severe traumatic complications that are associated a quarter or a third of the time for these patients, which can lead to extended hospitalizations and overall burden on our healthcare system and also the patient. So our lab is focused on interventional approaches, which are basically alternatives to open surgery that focus on reducing the surgical incision so that it can lead to things like minimal complications and faster recovery times. So one option that is very common is transarterial chemoembolization, where it's often a salvage therapy that tries to reduce the cancer burden for these patients. And by reducing the size of these tumors, it can often be a bridge to other techniques. But a more curative approach is known as radiofrequency ablation. And it's typically saved for early stage cancers. And again, it is curative or sometimes used in palliative settings to reduce the size of the tumor or used in pain management. But the beneficial thing about radiofrequency ablation, it is that it has a higher eligibility for patients. So about half of all patients that have liver cancer can be eligible for this type of procedure. And since we're using minimal incision sites, this leads to minimal complications. So less than 2% has been observed. And instead of being a long hospitalization for this patient, this is often performed as an outpatient procedure. Now in this procedure, you'll see here in the image on the right, typically applicators are used to guide are guided by ultrasound so that the tips of these applicators can cause basically cell heating, which will cause that cellular destruction. And on the day of the operation, this is basically the workflow that the physician works with. They'll get a preoperative 3D CT of the patient. The physician will identify where the cancer is in the body, which you can see here in the left panel denoted by the orange arrow. And after identifying where the cancer is, on the day of the procedure, they'll use real-time ultrasound so that they can get real-time adaptive information about the patient. But they'll be relying on the CT information from memory. So they'll basically be trying to perform this procedure on the fly. And again, after they identify where this lesion is, they have to get these applicators to that cancer site. And using this current workflow, local cancer recurrence has been observed up to 15% of the time. So to give you a better perspective of what the physician is working with, here is a live video sequence from our collaborators here at the London Regional Cancer Center. And you'll notice a few things. First off, you'll notice the anatomy is not static. The liver is a very deformable organ. The patient's breathing. As the physician applies different pressures with the ultrasound probe, things are moving around. So you'll see the liver in the left-hand side of the image, and then you'll see the gallbladder interface with the liver being the hypoechoic region on the right side. You'll also notice that a bright linear structure is evident in the image. And this is the applicator that the physician is inserting. And you'll see that it's not always in the same plane as the ultrasound image. And this is because the physician has this complex task of trying to identify where the lesion is in the liver at the same time as aligning this ultrasound probe with the applicator so that they can see where they're inserting, all at the same time trying to build this 3D context in order to provide sufficient therapy. So this really leads to our problem where therapy that really relies on guidance of the ablation probes is really hindered by 2D ultrasound since it is so subjective. And by using 2D ultrasound, it increases the mental burden on the physician and incorporates image guidance variability. So our idea was that if we could incorporate some form of 3D ultrasound imaging, then this could potentially provide more anatomical context that the physician could work with, which could improve planning and potential overall image guidance that they can use during these focal liver tumor therapies. So the aim and objectives of this project, again, is to develop an intraoperative system, something that the physicians can use with real-time ultrasound feedback. And specifically, we wanted to develop a system that was capable of providing accurate guidance of these applicator probes. So our goals were to develop the hardware and validate that hardware, develop software that goes along with that hardware to provide visual aids for the physician. And then my project has been to evaluate the system performance, mostly on a Phantom, but this is leading into a clinical trial, which has received ethics approval recently. So what we're proposing is to augment the current workflow. So traditionally, we have that 3D CT where the physician mentally plans their approach, and then they use 2D ultrasound to guide these applicators. But what if we incorporated 3D ultrasound before and after this live insertion procedure? And if we use image processing like image registration to match these imaging domains, then we can get information from the CT into the ultrasound space. And then by fusing that 3D information with our live 2D ultrasound image, we can then start guiding these procedures. And since this is the Adaptive Oncology seminar series, another benefit of having 3D ultrasound after the insertion is that we can start verifying these applicators so that we can be adaptable to different changes that happen in the operating room. So if the physician is not happy with their placement, then they can form subsequent 3D ultrasound scans without any harm to themselves or the patient, because again, ultrasound doesn't use any ionizing radiation. So it's a very safe imaging device. So the system that we developed is shown here. So you'll see here on the panel on the left, our system is mounted on a portable cart that can be brought right to the patient's bedside. It offers an arm that reaches over and can be placed on the patient. And in the panel on the right, you'll see basically the main components of the system. So we're trying to develop a cost-conscious approach to this procedure. So we're using 2D ultrasound probes to do this. And most hospitals already have 2D ultrasound systems with these probes. So we can already use technology that already exists. And by using custom matched 3D printed holders, we can use this to attach to our 3-motor scanner so that we can form different 3D geometries for scanning. Now this scanner is attached to a mechanical wrist, which is a gimbal joint that offers 3 degrees of rotational freedom. So you can think about it being the wrist of your hand. And then this is all attached to a counterbalanced arm and brakes so that they can move the system with a weightless approach so that it doesn't offer any impingements on the physician. And then when they place the probe in the position that they're happy with, everything locks because we're using electromagnetic brakes that are currently controlled by a foot pedal. So using these 3D printed holders and controlling the motors in different ways, we can form different acquisition geometries that range from the order of 4 to 12 seconds to acquire a 3D ultrasound image. And by manipulating these motors in different ways, we can form different reconstruction geometries. So if you just drag the probe in a linear translation fashion, you get this rectangular type image. But since the liver is so large and has different anatomical positions, we need to be adaptable to how the liver presents itself. So sometimes the liver can sneak up behind the rib cage. So if we want to start imaging behind the rib cage, then we need to image through the intercostal space. And this is something that the tilt scan can provide benefits for, since you can start peeking behind the ribs without incorporating those shadowing artifacts in our images. The liver is the largest internal organ in the body, so it is also beneficial to have a very large field of view. 1, so that you can see more. 2, it also facilitates things like more information for registration approaches, which we'll be investigating in the future. So the hybrid combines the linear and tilt geometries in this large field of view. Our system also features electromagnetic encoders, which are basically angle sensing devices so that we can track the probe's location in space. And you'll see here in the video in the middle that as I'm moving the system around, we can actually track where that probe is in space. So once everything is registered to the same imaging coordinate system, say with the CT and the ultrasound, once we work so hard to get that accurately, then as we move our device, we can basically get a sense of where our system is in the world coordinate system. And we've evaluated the system to have an accuracy of less than 3 millimeters. So in order to test the feasibility of using this system for an actual patient intervention, we need to show its effectiveness, and we do that using phantoms. So I created a phantom that used agar, and you can see little spheres to provide targets. And basically it's a mixture of cellulose so that it can provide ultrasound scatter. And there's also tungsten in there so that we can provide information for another imaging device like CT. So this phantom in the ultrasound 3D image looks like the image you see here on the bottom left. And in order to validate our system, we're not just relying on our system to quantify the error. We wanted to have an external imaging system to make sure that our system is not biased in any ways. So the workflow for this procedure was to acquire a 3D ultrasound image where we could get a visual representation of what the simulated anatomy would look like. And then we could identify targets that we want to navigate applicators to. Then after moving our system to that site and performing a needle insertion, we could then acquire post 3D ultrasound images to validate whether or not we're happy with that needle insertion. And again, acquiring a post cone beam CT image so that we have an external imaging validation source. We can then perform registration with these post-operative or post-insertion images so that we can get it back into the pre-3D ultrasound image space so that we can start assessing our needle accuracies relative to the targets defined in that pre-3D ultrasound image. So to give you an idea of what the workflow looked like, this is basically a snippet of one of those examples. So you'll see the live 2D ultrasound image from the ultrasound machine being fed into our image guidance software. And as the probe is moving, we can reconstruct that 3D image real time and on the fly. Then as we navigate to our targeting workflow, the user can then scroll through this image and look for regions that they want to hit with their target. And then when they find something that they like, they can identify that and actually move our system to that imaging plane. Something that we developed to facilitate an accurate needle guidance procedure is this custom 3D printed needle guide, as you can see here on the left. Since we use this 3D printed needle guide, we know all the geometry, we know all the dimensions relative to the ultrasound probe. And since we have this ground truth knowledge, we can then relate this probe to the live 2D ultrasound image so that once the probe moves to the ideal site, then we can tell the physician to insert, say, the needle in channel number 3 to a depth of 15 millimeters. And then that's how they can achieve the target based on the 3D ultrasound image. So we looked at over 15 needle insertions on a phantom. Obviously, there's going to be some registration error that will affect how to interpret our targeting errors. So after the images were registered, these were registered using a fiducial-based approach. And so we observed errors less than a millimeter for the registration, and taking that into consideration, using the ultrasound for verification, we can navigate to targets based on the 3D ultrasound image with less than 4 millimeters of error, and this slightly increases when using our external CT validation of 4.3. But again, some of this error is contributed by the registration error of the process. So this phantom experiment was going well, so we needed to prepare on how to prepare this for the clinic. So you'll see here that we performed a volunteer scan. So we have a volunteer lying on the bed who performs a breath hold so that we can form a 3D ultrasound image under static imaging conditions. And you'll see in the left, the ultrasound scanner that we're using to pull frames into our system so that we can reconstruct those 3D ultrasound images. And our volunteer scans looks like the ones you see here, where we can now start reconstructing these 3D images with improved spatial context. So now the physician can now start appreciating the complex anatomy and avoiding organs at risk like the right kidney, portal vein, or hepatic vein. And as soon as acquiring this image, the physician can manipulate this image in any degree of freedom. And you'll see that they can even start manipulating on oblique angles or imaging planes that are not conventionally seen by a regular 2D ultrasound probe, such as those parallel to the skin. So using this 3D ultrasound image, we can now start incorporating image processing to facilitate better accuracies. So if you have a 3D ultrasound image of a patient where you've identified where the applicator is, you can then start relating that applicator relative to the tumor segmentation, and using information about the ablation volume from these tips, you can then start assessing your margins before actually going ahead with the procedure. And this can inform the physician whether or not they need to perform any changes. And since we have these models, we can actually form a 3D representation of this scenario in 3D space so that we can start incorporating multiple needles into the workflow and let the physician know whether one needle or both needles needs to be adjusted or whether or not they've achieved a sufficient therapy. And this actually provided a unique workflow opportunity where we could facilitate something that quickly identifies needle localization to better improve the feasibility of this procedure in a clinical domain. So another project that we investigated was 3D ultrasound applications. for identifying these applicators. So as the physician scrolls through, they can pick a point that they've identified on the needle. Then using information about that point, we can then filter our image to better approximate where that needle localization is. Then we can form a spherical search space so that we can basically search trajectories in a 3D image on which are most likely to represent where that needle location is. And then finally, we can try to identify where the applicator tip is. And we use something called an Otsu threshold, which basically assumes that the needle is a foreground object relative to the background soft tissue. And the last point from the image edge that satisfies this threshold is what we're calling the needle tip. And after identifying this needle, again, we can automatically build these 3D models in space to use with our system. So we investigated this on a collection of 3D ultrasound patient images. And just to give a representation of some of the images that we worked with, this is a slice pulled from the 3D image. And you'll notice that it's not always easy to identify where these needle applicators are in the image. You can see that as we start having sharper and sharper needle insertions, up to sometimes 60 degrees, you start incorporating things like needle gaps or imaging gaps that doesn't show a strong representation of where the needle is in the image. So this actually incorporates some challenge into identifying our needles. So this algorithm was able to perform in less than a second, so very quick and very feasible for an intraoperative approach. And we used multiple users to test how robust this algorithm was, because it does rely on that user initiation type point. So you'll see here that on the left side of your screen, our trajectory error, and on the right side of our screen, we have errors relating to tip errors. And you'll see that there is variability across users. For the most part, tip errors were mostly on a median level around 4 degrees and 4 millimeters. But as you see on the image on the right, you can see that there is sort of maybe a training curve that is still dependent on our algorithm. So we're looking at ways to circumvent this and potentially develop a more automatic approach. And that's actually led to some of the work that I want to talk about next, and that's our 2D ultrasound segmentation. So again, you have the verification 3D ultrasound images to identify where these needle applicators are on the body, but the physicians are still inserting these needles using the real-time 2D ultrasound image. So our idea was if we could identify where these needles are during needle insertion, we could then project the trajectory that the needle is currently being inserted on to offer guidance as they're doing the insertion and not having to necessarily wait until that verification 3D ultrasound scan. So since we had a pretty limited liver data set, we investigated potentially a generalizable approach to doing needle segmentation, because liver ablation isn't the only procedure that uses needle applicators to perform therapy. So we had images from phantoms, prostate, and gynecologic brachytherapy, and then we had liver and kidney ablation images as well as biopsy images. So our images were split up into separate training and validation data sets, and we set aside some of these images for a test data set to evaluate the performance. And we trained and tested a 2D modified unit to do this approach, which is a deep learning convolutional neural network approach. So you'll see here in the bottom row the predicted masks, and you'll see that it actually performed relatively well across all anatomical backgrounds. So it seemed to be somewhat generalizable when incorporating all these different anatomical backgrounds into our method. But one of the limitations, what we found, just focusing on the liver and kidney results, is that these oblique needle insertions are actually quite difficult. So compared to something like the prostate or gynecologic brachytherapy, where the needles are parallel to the ultrasound imaging plane, these needles actually show up a lot better. So the algorithm had an easier time identifying where these needles are. But as we start going into the liver and kidney domain, our accuracy tended to drop again, because as you insert the needle at higher and higher angles, you start incorporating more artifacts into how the needle is visualized in ultrasound, which can lead to tip and trajectory errors, as you see in the middle and right panels. Part of the reason why there's error in these graphs as well is that sometimes the user was not repeatable when developing these gold standard ground truth segmentations. So dice coefficient is basically a pixel by pixel overlap metric. And you'll see here that the user repeatability is on the order of 90%. So for applications like the prostate or gynecologic procedures, we're sort of operating near that threshold, but we still have some work to do with liver and kidney results. And Also, when identifying the needle tip, it's very difficult for the user to be repeatable at identifying these tip locations. So we were expecting to see larger errors for the tip errors as well. So this is something that we're actively investigating in the future. And to give you a sense of where the errors are coming from in the liver and kidney images, again, I have that original video that I showed earlier in the talk with the predicted needle segmentation that our algorithm has been working to identify. And you'll see here, once the physician has inserted the needle and actually has the ultrasound probe aligned with the applicator, the algorithm actually does quite well at identifying where that needle applicator is. But it's when things are moving around, when the physician doesn't necessarily have the applicator in view, the algorithm always assumes that there's a needle applicator in the image. So it's always looking for linear type structures so that you'll see it catches on, say, the liver and gallbladder interface. So potentially in the future, we're looking at incorporating video information and reinforcing things that better resemble what a needle applicator looks like. But this still actually has clinical utility as is, because it can let the physician know whether or not they're correctly visualizing the applicator. Because if the segmentation is not producing a good result, this could be a good sign that the ultrasound probe is not aligned correctly and that they need to adjust what they're looking at. So just to conclude, focal liver tumor ablation really relies on adaptable technology, since it is a changing environment in the operating room, so that they can accurately guide therapeutic applicators and provide sufficient therapy for patients like Howard. And we believe 3D ultrasound and image processing can provide accessible methods to better plan, guide, and verify these procedures. And our system really provides the potential for reducing the local liver cancer recurrence rates that are currently observed. And we also have an opportunity to maybe change how these procedures are done by even treating larger tumors or tumors that are conventionally untreatable because they're complex. So if we can better visualize where these locations are in the body, then maybe we can facilitate higher eligibility of patients that can go through with these procedures. And as you saw with that last 2D ultrasound segmentation project, this system really has application to other abdominal vocal procedures, such as those found in the kidney, or not necessarily therapy procedures, but also procedures like guided biopsies. So in the future, we're trying to expand on what I've shown you today. So what we've sort of achieved so far is shown in yellow, but we're sort of moving into the CT space by working on things like ultrasound registration and doing things like target planning. And we had a collaborator in our lab that developed a CT planning algorithm so that we could develop an automatic method on performing these procedures. So you'll see here, we had optimization criteria, like trying to optimize the coverage of the tumor and optimizing the insertion angle while limiting things like forbidden structures such as the ribs. These probes only have a finite length, so we need to limit things like depth and also overlapping probes so that it can be physically achieved. And this was performed on a CT imaging data set. And again, since we have 3D images, we can start forming 3D models and basically optimize ablation volumes that completely cover our tumor volumes. And something that I've been working on is a liver motion compensation algorithm. Again, the patient is not static, they're free to breathe. And as they do their breath hold, sometimes they don't consistently perform the same breath hold every time. So we need to develop something that basically accommodates for this type of changing environment. So on that note, I'd like to thank all the collaborators that have helped me achieve a lot of the projects that I've shown you today, specifically Aaron Fenster and his lab in the 3D ultrasound space. And also, as we're moving into the clinical trial portion of this project, we have had very helpful collaborators in making this transition possible, as well as other scientists that have helped with their scientific input. And finally, I'd like to thank the sources of funding that continue to support projects like the one I've been working on. So thank you. I'd be happy to take any questions.